Hey everybody, welcome to CD Seminar. Hope you're having a good Friday afternoon after all the rain. Looks like the sun's going to come out. It's going to not rain for a minute. I'm going to let Dr. Fink introduce herself. She's new faculty this year. I think she's presented a couple of times, excellent presentations on substance abuse, a long history of research and teaching and practice in the area of substance abuse. And so we're glad to have Dr. Fink, who's my co-PI on this project now. So, Dr. Fink, I'll step aside and let you have it.
Okay, thanks. Thanks, everyone. As Dr. Brand said, I do a lot of research, especially in interventions and improving interventions, the efficacy of interventions. So what I thought I would talk about today are adult individual interventions for substance use, the ones that carry the greatest efficacy for their use, and kind of talk a little bit about the theory behind it and then the essential interventions. So I won't be like training you to do a particular intervention, but I hope to provide you with enough understanding of it so that if you go to a training or pick up one of the manuals, that you feel adept in using these interventions. And so I'm going to share my slides here. Get this set up. Okay, and I think this should look proper to everyone. So I'm just happy to be here again today, and we'll go ahead and get started. Let's see. So the learning objectives that I have for today is I hope you'll learn about the elements of evidence-based adult treatments for substance use disorders. And because of the high co-occurrence and comorbidity of substance use disorders and trauma and PTSD, I wanted to be able to talk about a couple dual diagnosed treatments that treat substance use disorders and trauma or PTSD concurrently. So at the same time, so you don't have to do those things sequentially. And just to provide some backup, the real commonality amongst all of these substance use disorder treatments and the ones that have a lot of efficacy is they're all based on behavioral principles. So if you reach way back into your like Psych 101 recesses of your mind, you'll remember, the discussions of operant conditioning and the principles of reinforcement. And so when we talk about these things, things that are reinforcing, it is solely evaluated by its effect on the behavior. So if you're going to, reward initiating conversation, for example, is the behavior you'd want to initiate, you'd have to reward that in a way that was real and reinforcing for that particular person. So just a smile, engagement in the conversation is probably likely to be something reinforcing for that individual. So when we talk about reinforcement, we have two types: positive reinforcement and negative reinforcement. So positive reinforcement is the addition of something pleasant in response to a behavior. So for example, in the prior example, it was the smile and the reciprocal engagement of conversation. Negative reinforcement is the withdrawal of something aversive. So if you're trying to encourage your children to make their beds at home, then maybe if they make that consistently for a week, then they don't have to take the trash out on the weekend or something like that. So it's the withdrawal of something aversive. And the goal of reinforcement is to increase a desired behavior. And the goal of punishment, which is not retribution, but the goal of punishment is to decrease an undesired behavior. So we again have two types, positive punishment and negative punishment. And so positive punishment is the addition of something aversive in response to a behavior. So having to do an extra chore for talking back to a parent. And negative punishment is the withdrawal of something positive. So losing video game playing privileges for not picking up a room when requested. And then we also have extinction. So if we ignore a behavior will eventually decrease and eventually cease if it's not reinforced. And, you know, this is kind of the most common intervention that parents are coached to give to kids who are young and are having temper tantrums. Just ignore it, and it will eventually drop to 50% and then go away after that. So these just kind of orient everybody, have everybody on the same page as we then talk about these essential elements of these treatments going forward. So the first treatment I'm going to talk about today is relapse prevention. This is a widely used treatment, has tons of empirical evidence. It was one of the treatments that was used in the multi-site national trial of substance use interventions that was undertaken by the National Institutes of Health and the National Institute on Alcohol Abuse and Alcoholism, called Project Match. And so some of you may have heard about that, but that was the single largest substance use multi-site study ever undertaken in this country. And relapse prevention is based on a social cognitive psychology that incorporates both a conceptual model of relapse, a set of cognitive and behavioral strategies to prevent or limit relapse episodes. So even decades ago, when this intervention was developed and tested, there was the understanding that substance use disorders are a chronic health problem, and that limiting and preventing lapses is the best method to long-term positive outcomes for these patients and clients. So the central aspect of this model is a detailed classification of factors and situations that can precipitate or contribute to relapse episodes. So the people, places, and things that serve as cues and precipitating factors for people to return to substance use. So there are also some distinct variables that contribute to relapse that have been identified in research and in investigation of the efficacy of this treatment. So we have immediate determinants. So these are high-risk situations. They're the coping skills that people have on board. They're also the outcome expectancies. So what if I drink, what's the expectancy that I have? Am I less anxious? Am I more social? Do I feel relaxed? Expectancies of substance outcomes are huge drivers of the use of substance. And then we also have the abstinence violation effect. So let's say someone goes down the line and they do slip up and use again. The abstinence violation effect is like, well, I drank, so I might as well just forget it all. And then they return to their level of heavy drinking. Then the covert antecedents that contribute to relapse are lifestyle factors. So hanging around people and places that contribute and support drinking. So hanging around the other, the old group of drinkers or people you used to use with are kind of those lifestyle factors. And then also the urges and cravings that are physiological cues for drinking or drug use for folks. So let's talk about these immediate determinants in these high-risk situations. I kind of alluded to some of this, but they're pretty darn interesting. And there is a lot of the intervention that is focused on these high-risk situations because of how potent they are in predicting the return to substance use. So the first one here is situations with others, particularly interpersonal conflict, and then the resulting negative emotional states that come with having a fight with someone. We've known since the mid-90s that this accounts for more than half of all relapse episodes. Somebody has had some conflict with someone, and within a little while, they've returned to drinking or drug use. So that's half of all relapse episodes can be attributable to some interpersonal conflict and the negative emotional states after. Then we also have social pressure. So this is direct verbal. So like offering someone a drink or saying, you know, geez, just one, you can have one, it's no big deal. Or nonverbal persuasion and indirect pressure, like just being around people who are drinking. We know that this accounts for 20% of relapse episodes for folks. So in relapse prevention, we have big focus on situations with others and social pressure because that accounts for 70% of the slips and return to substance use. Then we also focus on negative emotional states, including, and we call these intrapersonal high-risk situations. So mood states of anger, anxiety, depression, and boredom. Boredom is a huge precipitator of substance use. And so the interventions focus around the perceptions of certain situations. So for example, coming home from work and being lonely and bored. So what are you going to do in that situation so that you don't just walk over to the fridge and pull out a beer and crack it open and sit down in front of the TV? Also then reactions to environmental events. So for example, how are you going to better cope with feeling angry about finding off you might be laid off at work instead of just, you know, might as well forget it all. I'm going to go swing by the bar on the way home. And then we also attend to positive emotional states here, exposure to alcohol or drug related stimuli or cues, also testing one's personal control and non-specific craving that they may have. So some people, and I'll talk about this in a second, when we do a functional analysis of their drinking or drug use, what we find out is some people tend to drink in response to positive emotional states. I just got paid. I worked a hard week and I just want to relax now and feel, you know, I successfully completed something. So it's a little bit more of a celebration. So we really try to structure interventions around those states as well. And then, you know, exposure to cue related stimuli. So this could be just, we call it seemingly irrelevant decisions. They decide to, out of habit, take a certain path home, and it happens to go right by the liquor store where they used to buy their booze. And so before they know it, they're in the parking lot and they're in the store and they've purchased something. And so that's because of all of those alcohol related cues that were in the environment that says, hey, brain, you know, we see this, pretty soon we're doing this, we do this, and then pretty soon alcohol's on board. And then we also see that people will test their own personal control. So they'll go to a bar to see if they can control not having a drink. And that's like rarely successful. So we have interventions that target that too. And then we also focus on coping here. So this is a person's coping, and I sort of alluded to this already, but how do we cope with these high-risk situations? And how successful they are is a critical determinant of the likely outcome. And if a person can cope successfully, then they have a good sense of mastery over a particular risky situation. This increases their confidence that they can remain abstinent, and it increases their feelings of self-efficacy. And it's incredibly critical to, unpack this so that the person is coping with the lowest level of intensity of cues and emotional states in that high-risk situation as possible. So start way early in the process. And then, as I mentioned, these outcome expectancies. So these are the expectancies for the positive effects of alcohol or drugs. So a lot of people who have substance use disorders anticipate only immediate positive effects and discount potential negative consequences for excessive alcohol use. So they focus on the immediate stress reduction, and they neglect the possible delayed negative consequences of further and continued disruption to their family relationships, close relationships with others, the negative impact this has on their job, and things like that. And these expectations for positive effects of alcohol and drugs are particularly salient in these high-risk situations where the environment is blinking at this person like, hey, everything awesome here is going to happen if you have some alcohol or drugs again. Part of that is the dopamine response that is occurring in response to those cues for substances. And then lastly, here we have our abstinence violation effect. So a lapse greatly increases the eventual relapse. So if a person slips and then they attribute that slip to something stable, global, internal to themselves, they are more likely to abandon abstinence attempt and will progress to a full relapse. So if that person slips and has a half a beer or a beer, then they're going to be like, I'm just a failure. That's a stable. This is just going to be my life for the future. That's a global thing. I don't have enough control to do this on my own. This is an internal factor. And so then they're much more likely to progress to a full relapse. So we spend a lot of time in this treatment restructuring those cognitions. And then we've got our covert antecedents and our lifestyle factors. So the lifestyle factors are the degree of balance between external demands, the shoulds, and the internally fulfilling or enjoyable activities, the wants. So one thing that we see here is that chronic stress significantly enhances a person's desire for pleasure and rationalization that indulgence is justified. So if a person is experiencing chronic stress, either from living in an unsafe or violent neighborhood, chronic stress from disrupted relationships, high stress work, it's much more easy. There's more of a desire for pleasure, and they're much more likely to rationalize their use of substances. You would be shocked to find out the Hazelden Betty Ford Foundation did a big study probably 4 years ago in conjunction with the National Bar Association. And being an attorney is a high-stress profession. I was astounded to find out about 60% of attorneys had misused a stimulant in the past month. So it's a high chronic stress environment, lots of demands to stay alert and on top of things. and just rampant substance use. And so for some folks, especially folks who live in our more socially disadvantaged neighborhoods and towns, rural communities where there's little opportunity for good jobs and things are stressful, not a lot of things to do. Drinking and drug use is often the only means that these folks have for obtaining pleasure or escaping pain. So that's why we tend to see these problems so overrepresented in those communities. And then we also talk a lot about urges and cravings. So an urge is a relatively sudden impulse to engage in drinking or drug use. I remember my dad was a smoker when I was growing up, and us kids hounded him to quit smoking. So he quit smoking. He had been abstinent from nicotine for like 20 years. And he said one day he just got a craving and an urge to smoke a cigarette that just about brought him to his knees, and he was relatively unaware of what brought that on, but it's a very sudden impulse to engage in drinking or drug use. And then craving is more of a subjective desire to experience the effects or consequences of drinking or drug use. It is often elicited by conditioning to stimuli that's associated with past gratification for the substance use, as well as cognitive processes associated with an anticipated gratification from substance use. So interventions in relapse prevention really target both of those conditions. And so this is just an example here, a diagram of over here on the left, a high-risk situation. If a person is able to engage in an effective coping response in response to a high-risk situation, let's say they just had an argument with their partner, if they can cope with that negative affect that comes from that high-risk situation of the argument, and they cope effectively with it, they feel stronger and like they can control their responses there. They have increased efficacy, that they can actually withstand the urges to use, and they have a much decreased probability for relapse. If, however, they engage in ineffective coping, like they continue to ruminate about the argument they had, they'll experience decreased self-efficacy to avoid the substance use. They will also experience a positive outcome expectancy for the effects of alcohol. If I could just sit down and have a drink, then I could finally relax and put this behind me. And much more likely then to have a lapse, which is the initial use of alcohol or drugs. They often then experience this abstinence violation effect, like, well, I drank, so I might as well just forget it all now. And continued positive effects of alcohol. They have a much increased probability of relapse in that situation. So you can see why there's so much emphasis on this treatment in effective coping with these high-risk situations. So the intervention strategy is mapped completely on to what I've just discussed. So we identify and cope with high-risk situations. We do a big functional analysis of their drinking. We want to enhance their feelings of self-efficacy and confidence in their ability to remain abstinent. We also work to eliminate myths and placebo effects of like the good things that substance use brings. And then lapse is almost inevitable. I sometimes hope this sounds odd, but I'm never too disappointed when a client of mine has a lapse because it provides such a rich learning opportunity that helps their subsequent coping with other high-risk situations. And then we work on cognitive restructuring to modify attributions of the relapse process for them. I'm going to take a drink of water here. So this diagram is another diagram of the substance using process. So the boxes that run through the center of this diagram are really the steps and the key pieces of someone having an initial substance use and then engaging in an abstinence violation effect. So we're having some lifestyle imbalance, too much chronic stress. Things are just, out of balance for them. There's a desire for indulgence. So interventions in relapse prevention that we utilize to deal with this are trying to increase lifestyle balance. For example, developing positive addictions like jogging, meditation, body time, and substitute indulgences. Going out for ice cream or spending time with loved ones, doing other fun recreational activities, getting a massage, things like that. And then to deal with urges and craving, there are stimulus control techniques like removing all items that are associated with alcohol or drug use. And for urge management, using coping imagery or urge surfing, which is imagining the urge is like a wave in the ocean that comes and crests over you and then washes back out. So it's not something that you necessarily need to give into. Then we'll do a revised decision matrix, which is kind of a pros and cons of using, and then provide some education about warning signals of relapse, like positive expectations, lifestyle imbalances, and also doing a strong analysis of high-risk situations and the available choices that are available, especially early on when there are so many different options available. We teach folks avoidance strategies, so how to avoid those high-risk situations. Also how to engage in self-monitoring and behavior assessment when they're in those high-risk situations. So really teaching them how to check in with themselves and what they do and what to do when they excuse me. When they find themselves in trouble. So just a lot of really detailed interventions here that are associated with this that target each of these key components of someone returning to a relapse. And for the sake of time, I'm just going to move on here. This is an example of a decision matrix for alcohol abstinence versus alcohol use. So we talk about immediate consequences and delayed consequences, both positive and negative. And we try to do it in a completely non-judgmental way and just put everything out on the table so that, and then write it down so that if the patient is in the midst of a severe craving incident or in a high-risk situation, they can also pull that paper out and review it so that they don't have to try to remember, like, what were the positive delayed consequences if I remain abstinent? Okay. Our next treatment approach here is the community reinforcement approach. And this approach also laid the foundation for the community for CRAFT, which is the community reinforcement approach and family training. And so CRAFT is an intervention for the family members of a substance using loved one or concerned significant others. And we work with the family so that they use these principles of reinforcement that I talked about at the very beginning to restructure their interactions in the environment with their loved one to increase the likelihood that person will enter into treatment and become abstinent from substance use. So this is the foundation CRA, also for CRAFT. So there are two major goals for CRA. The first one is the elimination of positive reinforcement for drinking or drug use, and the enhancement of positive reinforcement for sobriety or recovery. While all of these approaches believe that the patients should set their own substance use goals, some want to return to controlled drinking and are able to do that, and the intervention is flexible enough to allow that. I think you'll see they all pretty much talk about kind of abstinence as a potential goal. But just keep in mind, there's significant flexibility around that. The central tenet of this model is that if we rearrange the person's life so that abstinence is more rewarding than drinking or drug use, the person's more likely to be able to reach their treatment goals. So the treatment strategies that are used with CRA is focus on increasing the client's motivation to stop drinking or drug use. So identifying positive reinforcers. And I'm sure you can reflect on your own clients, but most folks quit doing everything else pleasant besides their substance use. All other pleasant activities have completely fallen away. And so the pleasant activities list is a real critical component of this website, of this intervention, and can be downloaded from the CRA website. It's free to use. And then we also want to identify negative consequences of substance use. So the inconvenience review checklist, which is a list of frequent negative consequences that come from substance use, with a focus on the medical, the marital, the relationship, and the work. Those are the major areas impacted. And then there's an encouragement of a trial period of sobriety. So just asking, the patient, do you think you can try not drinking for a month? And they found that this was much more efficacious than giving clients a firm prescription. So clients who were explicitly given a choice about a trial period of abstinence were much more likely to abstain than saying you need to be abstinent while you're in this treatment or for the first month or something like that. And then again, another key feature here of this approach is performing a functional analysis of the client's drinking. So again, we're identifying high-risk situations. We're identifying positive consequences of drinking. And this is the most underutilized, but most successful, especially in tailoring treatment to particular clients. So I highly recommend this. Like, what are you getting out of drinking? And also then the analysis of the client's drinking pattern. Are there certain patterns that arise, and so then you can identify mood states, times of the week, and schedule other reinforcing activities around those times when they're most likely to engage in the highest amount of drinking or drug use. So here's one of the worksheets that comes with CRA. So it's identifying external triggers, internal triggers, what's the behavior you engage in, and then what are the short-term and long-term, short-term positive consequences and long-term negative consequences of that. So who are you usually with when you use? What are you thinking about? What are you feeling physically right before you use? What are you usually feeling emotionally right before you use? And then you just go on down the line. What then do you do after that? How much do you use? What are the positive consequences? Well, I feel like a little relaxed, or I feel euphoric because I'm hanging out with my friends. But then what are the negative long-term consequences of that? Well, you know, I'm probably not going to go to work the next day and whatnot. So the treatment strategies of this approach are to increase positive reinforcement associated with not drinking or drug using. And this, as I mentioned earlier, the range of non-drinking, non-using behaviors narrows substantially when a person has been heavy drinking or using drugs heavily. And so we want to also really increase contact with non-drinking people activities and encourage them to engage in activity sampling. I mean, there's no harm in going out and trying something once to see if you like it. You know, go try, you know, riding a bike around Lake Hefner. If that's too much, then, you know, or boring, don't do it again. But, you know, trying different things so that they can find activities that are reinforcing to them that they had forgotten about. And then we have them rehearse new coping behavior. We do this a lot in session. So we practice and role play in session. And even though it's awkward for the patient at first, it is exceedingly helpful. And I get so that my clients then ask me, you know, so what would you say in this situation? I said, well, let's play it out. And this is particularly important involving interpersonal communication, especially around conflict resolution. And then as much as we can, we want to involve clients' significant others. And this is where CRAFT really, you know, branched off and became its own intervention as well. So clients' concerned significant others are helpful in identifying social context for use and can support change as well. So we can teach concerned significant others strategies and new skills to be supportive in using this reinforcement model that are alternatives to, you know, the nagging and the pleading and things that they're probably engaging in. Okay. Any questions or anything from the group before I go on to our dual diagnosis treatments? Okay, I'm going to take that as a no. So our first dual diagnosis treatment that I'll talk about today is seeking safety. I love this treatment and I use it widely. I have the link at the end of these slides for how you can obtain this manual. But this helps clients obtain safety from trauma and substance use. It can be conducted in groups or in individual settings, and it addresses both trauma and substance use without required delving into trauma. So that needing to delve into the trauma is often a significant barrier to treatment engagement for folks, because our efficacious treatments are prolonged exposure and cognitive reprocessing therapy, both which require exposure to the treatment. And some folks just don't have the coping skills in place yet to be able to do that. And because of that, Seeking Safety is really agreeable to a broad range of clients and is very easy to employ. So with prolonged exposure and CPT, you really have to have a lot of training and make sure the environment is structured well enough so that the patient doesn't really kind of decompensate as they are going, through these very painful memories. So Seeking Safety is a really good strategy. In my prior treatment setting, we actually did Seeking Safety first before in our trauma recovery program. We did Seeking Safety first, and then our patients went through prolonged exposure or CPT to address their trauma straight on. But the Seeking Safety was to give them some coping skills so that they could cope with the difficult PE or CPT treatments. So Seeking Safety is a manualized treatment that requires little training. Najabitz is the author of it, and she really developed it to be a very easily accessible treatment. And so I'd really encourage everyone to give it a shot. The key principles of Seeking Safety are, number one, safety. So the overarching goal is to help clients attain safety in relationships, thinking, behavior, and emotions. It's an integrated treatment, so it's working on both the trauma and the substance use at the same time. It has a focus on ideals, so it counteracts the loss of ideals in both trauma and substance use. The thing that is so beautiful about this treatment is before each session, there is a quote. It's an inspirational quote that just like really, communicates something impactful. For example, one of them that I like the best is "no feeling is final." So a lot of folks are feeling like they are never going to recover from this. They'll never be normal again. And that really is it contradicts that. It has 4 content areas, so it addresses cognitive, behavioral, interpersonal, and case management. For myself, I don't use much of the case management. And in my prior treatment setting, we had case managers who could help the clients with certain things, but you may find in your own practices that you do a fair amount of case management, and this is a helpful manual for that. And then there's also attention to clinician processes, so clinicians' emotional responses, clinicians engaging in self-care, et cetera, because treating substance use and trauma can be really exhausting for folks, and they may experience some secondary negative consequences as a result. So there's really a nice focus on making sure that the clinicians are in their best state as well. This is a highly flexible model. So there are 25 modules to this, and the clients go through and pick out which ones seem to be most applicable to them. And so it's appropriate for both men and women, and it's appropriate for any length of treatment or setting. So outpatient, inpatient, or residential treatment. And clients actually do not need to meet a formal diagnosis for PTSD or substance use to actually benefit from this treatment. And I tell you, they have the best grounding exercises that I've seen of any treatment manual out there. So emotional grounding, physical grounding, and self-soothing. And I use it with all of my anxiety clients, depression, and things like that. Anybody who is getting overwhelmed by a strong emotional state they've found it very helpful. So as I mentioned, there are 25 topics that the client and clinician can choose based on the client's needs. It can be delivered in 12 sessions, kind of our standard therapy course, and can be conducted in any order and as few or as many times as time allows. So this here in italics is just some examples of what the modules are. So there's, module on compassion, recovery thinking, healthy relationships, setting boundaries in a relationships, this detaching from emotional pain, or the grounding, which was the example that I just gave you, creating meaning. I mean, it's a really lovely treatment. And the next dual diagnosis treatment is called COPE, or the concurrent treatment of PTSD and SUDs with prolonged exposure. So this is a treatment that requires a little bit more training to engage in, but you can buy the manuals from the Oxford Press under their series of, I think it's Treatments That Work is what the series is called. And again, this is a behaviorally focused treatment. It has 12 sessions with a heavy focus on PTSD. And the substance use treatments follow the relapse prevention type of model. And the treatment goals also follow a SMART goal format. So they're specific, they're measurable, they're attainable, they're realistic, and they're timely. In other words, they have a time frame. In the next 3 weeks, I'm going to, make sure that I exercise twice a week each week, and so that's all set out for them in the SMART goals. But that really reduces the feeling of being overwhelmed by the prospect of engaging in this treatment for patients, because it really breaks it down into nice, measurable chunks. And so I just, here on our last slide, I got right through this, I see pretty quickly. I've got some links for you where you can find these treatment manuals, so you can find information about relapse prevention and get a manual from recoveryanswers.org. And then Seeking Safety, the manuals available here at treatmentinnovations.org. You can buy the manual it's a big paperback form, or you can buy a PDF copy of it, which I like quite well, because then I can just print off the sessions and the exercises to give to my patients. I don't have to photocopy a book or anything. So that's a really nice option there. And then I see I didn't put community reinforcement approach up here, but that is available. I should, before we upload these slides, I'll put that in there. Robert J. Myers, PhD, it's available from his website there. He has a ton of resources, as well as training opportunities in CRA and craft for folks. And then COPE is available from the Oxford University Press. If you go to this website here, you can buy both the therapist manual and the client workbook. And the nice thing too about buying the manuals, these are also these treatments that work that are sold by Oxford University Press. And you can then access all the client worksheets and things as PDFs from the website. So it's easy to print them off and then hand them over to your clients. And so I'm going to stop there. I can leave these slides up and just open the floor to any questions or comments from folks. I know I gave you a lot of kind of high level information today.
I just like the way this gives people so much dignity and respect throughout this whole process. I think that just suits my value system so much, you
I
know?
love it. Yeah, I love it too. I mean, you know, our patients, our clients, they deserve to be happy just as anybody else does. And I use relapse prevention a lot too. And this week, with a client of mine who had, you know, decades long history of heavy alcohol use and dependence, you know, he had a lapse. And so he didn't come to session last week, but he came this week. And as he's walking out, he is reminding himself that this is not a judgmental place. This is, you know, this is a friendly place where he can come and just explore all of these things and we can work it out together.
Right.
Yeah. Yeah. I'm right there with you, Lenore. Any other comments or questions, or anybody else use these treatments?
I just, the only thing I'd add is, you know, with the CBT thing and the diagrams that you lined out there, you know, I know working with folks over the years, you know, it'd be like, well, you know, my truck just ended up at the bar at the,
Yep.
at the liquor store. I don't know how it got here. So,
Yep.
you know, that's really not the case. And so being able to talk about urges and cravings and permissive beliefs and reliefs and all those kinds of things that, you know, slowly kind of add up to a relapse and start weeks or days before the relapse actually occurs.
Yep.
To kind of get into the habit of breaking that down and using those terms and concepts, it really does demystify the whole thing for the patient, I think.
Yep.
And I think it's something, you know, we may need to have a whole session just on that at some point to kind of break those concepts down and give some examples. But I think it's
I would love
a
it.
good thing for folks to know.
Yeah. Yeah. And the seemingly irrelevant decisions, you know, that's another thing, you know, then my client just he's kind of talking about things. This was a few sessions ago. He's like, seemingly irrelevant decisions, you know,
Mhm.
I'm
Yeah.
going to take a left or a right out of my neighborhood to go get gas.
Mhm.
And, you know, seems like it doesn't make a difference, but yep. All of a
Yep.
sudden he's at the old gas station where he used to buy his beer. Yeah.
Yeah, so that's very good. Well, we got a minute. I just want to mention that we're going to have our old buddy back, Rojas, next week. He's going to talk to us. And then on the 19th, that'll be the last one of this year. Our new addiction psychiatrist, Dr. Bartell, is going to talk with us. She'll talk some about what she does here with MAT and the CARES program. So we'll finish out. We're finishing on a strong note this year. So any other questions or comments for Dr. Fink before we get going?
Thank you so much, Dr. Fink.
You're welcome, Lenore. My pleasure. I love talking to this group.
All right, guys, I guess, Dr. Fink, we can let everybody start their weekend 8 minutes early. How's that?
That sounds fantastic.
All right.
All right, everyone, enjoy the warm weather.
Yes.
Yeah, see ya. Bye-bye.
Bye-bye.